Welcome back to the Pod Doctors. I'm Dr. Raafae Hussain, and today I have Dr. Jordan Meyers with us from Raleigh, North Carolina.
Raleigh, North Carolina.
Wow.
Excited to be here. Thank you for having me.
Yes, of course. So today we're talking about the TayCo ankle brace, a pretty much one-of-a-kind device used for a lot of ankle problems. I mean, it's one of my favorite braces that I use in the office, so hats off to you. This is phenomenal. So, how long have you been a podiatrist? Let's just start off basic.
So I have been back. I'm from Raleigh. I moved here when I was 10, so I did most of my growing up around here. And then luckily was able to join back the practice that I kind of shadowed growing up from undergrad and beyond. So we've gone through some internal structural changes. We're part of a super group now, and we're an equity-backed super group. And so been fun to watch a lot of the growth pattern in terms of being able to provide an awesome product and help a lot of patients in a lot of different ways. So shameless plug for a group that I like a lot and that it's been fun to be a part of.
What's the name of your practice?
I've been back for... I'm sorry?
What's the name of your practice?
So we're Raleigh Foot and Ankle Specialists, but our larger umbrella is U.S. Foot and Ankle Specialists or Foot and Ankle Specialists, the Mid-Atlantic. You'll hear a couple of different names that float around through there.
So anyone in North Carolina who's got foot and ankle problems, come see Dr. Meyers. He is phenomenal.
Checks in the mail, Raafae. Thank you, sir. So I've been back for 8 years now, but I'm a hometown hero, self-proclaimed, and so excited to come back and do a job I love for a community that I love, and just try to be integrated every way that I can. Family's all here. My wife's family's the same way, so it's cool to be back here and take care of these people.
Yeah, that's the best. Family, community. It's nice seeing patients about. So I live in the same area I practice in, and I'll be like in the grocery stores, and they're like, "Oh, Dr. Hussain." I'm like, "Oh my God, hey, I love your boot. It looks great."
Right. It works well. Yeah, I talk a lot of feet after hours, which is pretty fun because, same with you, right? When you love the job, it doesn't matter where you're at and when you're doing it. And you see somebody in the grocery store line and you want to chat about it, or that patient you haven't seen in a while. And hey, how are things going? By the way, I haven't seen you in a bit. I guess that means it's good, So it's fun to do that.
My favorite opener is whenever I see somebody that is probably possibly not mine, possibly someone else's. I'd like they'll be walking in a boot or something, because that's how you know for the most part that they have foot problems, right? And I'd be like, "Oh, I love your shoe," and they're like, "Oh yeah, I got a Jones fracture," or I got like something else. I'm like, "Oh, I'm a podiatrist here in the area. If you don't have a podiatrist yet, if you got this from the ER or whatever, or your primary, come see me." And it's just it's simple, community outreach.
Absolutely. It's such a great idea. It's just, I think it helps people understand, how much you love your job and you love helping people. Because if you're going to take the time and energy to just talk to the random person who comes by in a boot, plenty of doctors probably saw that same person and never said a thing. But when you got a big heart and you care a lot, you just go, "Hey, how are you doing? Is everything okay? And are you making progress? And who do you see? Oh yeah, Dr. So-and-so is great." It's kind of fun to go down that rabbit hole and have that conversation with patients and give them that confidence that there's light at the end of the tunnel and they will get better.
Yeah. So talking about boots and braces and stuff. So today we have the TayCo ankle brace. It's a one-of-a-kind device. It fits around your shoe. It pretty much works like a cam boot or a fracture boot in the sense that it locks up the ankle, except it has some nice little differences that make it that much more better. It's honestly one of my favorite boots or braces. I don't know what it's considered or classified as, but it's a phenomenal thing for patients. And honestly, it's one of those niche devices that I swear is so underutilized.
Absolutely. No, that's well said. I think that, this is a big momentum change in terms of trying to get a lot of doctors to rethink what they've done for a very long time, right? Like, when did the cam boot come out? Probably in the 1800s. I'm not sure.
It's been too long.
Yeah, too long. And it was just our standard of care because we were all just part of the system, right? And you're like, well, that's what all the doctors that I trained under did, so I think that's what you're supposed to do. And so it was just this easy, usable, kind of functional, kind of works in the right situation, kind of helps. And it's, what are your other options, right? And in the shoe brace, that perhaps is not as restrictive and not as supportive. So you just knew that you're not going to like this thing, but this is what I got to put you in. So, I agree with you. Kudos to the team at TayCo to say there's better patient care, there's better patient outcomes. We are under treating patients, we are mistreating patients by just dumping everyone into this boot. We have to find a different solution that will help in so many ways. And they've knocked it out of the park. And of course, they came out with the iPhone 1 and now they're on the iPhone 4, right? So I love the research and development to continue to make every little piece of that brace better, which comes with people using it and also great doctors like you who give feedback and say, hey, let's try this. And what do you think about that? Change the momentum arm and all the great biomechanical studies that come out. So I know we'll get into some of that, but yeah, it's been a cool road.
Yeah, 100%. Because if you think back on original, immobilization, we use plaster casts. Remember those? You throw plaster pretty much. You have a dedicated room that was meant for all your plaster cast, and then came out the fiberglass casts, and then the boot, and now we're moving on to the TayCo ankle brace. I mean, it's literally the progression of medical management. So
No,
we have.
I'm sorry. That's a great way of saying it. That really is. Yeah, we were very barbaric back then, but look how far we've come, right?
Yeah, that's the truth. So we have a picture of a boot here. So this is your classic fracture boot, classic cam boot. We'll put these on patients, all the time. And the biggest complaint, honestly, it isn't the boot itself, but the effect that it has on everything else going on. That's honestly what I see. Patients will say, "Oh my God, my knee is hurting, my hip is hurting. I feel like I'm walking wonky." And we have these different devices that we can use to kind of lift up the other shoe, but then it's like you're walking on platform shoes afterwards,
Right.
which is another problem in itself.
I agree. And just a quick note. I mean, look how sad the people in that picture are, right? They're not happy. They're sad.
Yeah. Yeah,
The boot does that to people, right? It brings out the sadness inside you. So, although and you bring up a great point that a lot of times we rob Peter to pay Paul. I mean, how many times have you had a patient come back and say, "That kind of helped my foot, but my knee is killing me. My hip on the other side, or Dr. Sand, I couldn't even use it because after 3 days, my back was so messed up. I wasn't able to, I had to go see my chiropractor. Now I'm even worse off and my foot still hurts." So again, we just embrace that as the norm for our medical standard of doing it. And it was really just inadequate care.
Yeah. Yeah, you're telling patients you got to wear a taller shoe on the opposite side to bring up the height. There's little devices that you can slip around that opposite shoe to kind of balance it out. But honestly, it's like you're fixing one thing and then you're fixing the aftermath of that initial fix. When there's other better devices out there, and hit nudge nudge.
Yep, you're absolutely right.
So I'm just gonna skim through these slides here. I mean, big, clumsy boot. We already know this. They're pretty heavy, also. I don't know if you out there listening have ever worn a boot, but it feels like you have like a 10-pound weight strapped to your foot. I've broken my ankle in the past, and I put one of these boots on, and it's like you're lugging around, a textbook strapped to your foot.
Yeah.
And when you're sitting there or laying there, and it just wants to lay on one side, and you can't move, you're like, is there a better option out there? Do I have to wear this boot? And I see why patients are sometimes non-compliant, but you have to do something to give yourself support. And our only option for the last couple decades has been this boot.
Yeah, it's torture for sure. And like you mentioned before, that usually they say, some studies I've read say that up to a third of patients will complain of pain in a new area for 3 months afterwards. Maybe a long time after the foot's better, they're still hurting at that other body site that you accidentally injured through that. It's unless you're at a big orthopedic group and you want to make your partners busy, right? It's not great to be able to offer that where you're robbing Peter to pay Paul and people are hurting in new areas. It's definitely substandard care.
All right. So the TayCo ankle brace. So I'm going to jump to the benefits because that's the biggest factor in all of this. One, it's much, much lighter, by far much lighter. I mean, honestly, it feels like you're holding a stack of papers versus like holding a textbook kind of difference. I don't know what the actual weight is. I mean, you might know, but it's next to nothing. Honestly, it feels like a couple pairs of socks.
14 ounces.
14 ounces.
Yeah, I think lightest cam boot on the market's like 3 to 4 pounds, and that one's 14 ounces, so much lighter. Yeah. But even again, that's the best of the best for cam boots. A lot of places don't offer that, especially going to the ER and just getting whatever the run-of-the-mill cheapest boot they have there is. It's going to be pretty heavy and clunky.
Yeah, honestly, I'd probably bet the boots that we see around most often are probably like 5 to 10 pounds easy, I believe, without even trying.
Totally.
The no limb discrepancy factor. You're not changing the height of one limb versus the other. That's honestly the biggest benefit of this, I think. Like we said, when you're wearing a cam boot or a fracture boot, you're pretty much giving this guy a platform shoe on one side and telling him to walk around and hope that their foot and ankle gets better due to the immobilization, but not factoring that height difference. The TayCo ankle brace, it fits around your favorite shoe or your most supportive shoe, and it literally keeps that same height across the board, which is phenomenal. I think it's genius. I don't know why no one thought of that.
The same, yeah. They changed the lever arms and they made it a little bit longer on the sides to really be able to lock in that rear foot space. But the no leg length discrepancy has been huge for patients. I feel like I almost got better at explaining to patients how frustrating the boot can be when they come back for follow-ups. That I've had to, I don't use any of that verbiage anymore because people just come back really happy in this brace without all the extra issues of dealing with, like you said, that leg length discrepancy that can really cause a lot of issues going forward.
Last thing that I think is the biggest factor in all this is the fact that there's a hinge to this brace, classic hinge that you can actually move your ankle up and down versus your boot where you're locked at 90 degrees and stuck in that position. So when you're trying to transition people to get to full activity, you can unlock the hinge factor in this and get them light motion versus full motion.
Absolutely. The big thing is the continuum of care that you can get with a brace like this. Because like you said, on day one, early on in the process, whether you're post-surgical or the injury is more severe, you're more inflamed, you need to really lock down that rear foot and ankle motion, then great, your hinges are locked. And then as they come back a few weeks down the road, and whether they're progressing in their post-operative protocol, because like we talked about earlier with total ankles, or fracture care, or again, as the inflammation becomes less, and we want to allow some more motion to kind of decrease in the atrophy to the body or muscle wasting, then you can pretty much start to unlock hinges and allow for more motion through there and continue to advance. And I think that's especially important with a lot of the Medicare with their similar rules that are affecting a lot of doctors. How, traditionally you go, all right, here's your boot, and then you suffer your weeks of misery. And then you just don't want to go put a shoe on and walk because then everything starts to hurt again, right? That much immobility, that really locks them into place. That much muscle atrophy and tissue wasting and deconditioning is tough to come back from. So having something that can kind of grow with the patient, where you can, instead of trying to give them 3 different braces traditionally, which you can't anymore with Medicare, right? They're really strict in the rules now. Instead of telling patients, well, hang in there and I hope you do well, you can actually allow this brace to grow with the patient and meet them at their place of where they're at in the healing protocol.
It's one of these things that no one's really talking about. Insurances have transitioned to, you get one durable medical equipment device and you're stuck with it for either a year or some insurances 5 years, right? You give them a boot and that's it. You can't give them a brace. You can't give them an AFO. You can't give them anything. And a lot of the times, patients will have a boot from the ER where they were originally seen, and then they come see me. And I'm like, oh, we got to put you in this or that, and they're stuck with that boot because the insurance won't cover it. And they're like, oh, what's the out of pocket, price for all this? And I don't like selling things to patients. I mean, honestly, I'm not a car salesman. I'm trying to get patients better. I'm trying to, optimize, their insurance. I don't know what else to say to that. It's a silly thing. But the nice thing about this is you start off at locked position, right? This is typically my protocol, right? Patient comes in, severe PTTD, posterior tibial tendonitis, right? That's one of my most favorite devices for that. They've had long-standing foot and ankle problems. They're not an ideal candidate for surgery. They've done, different orthotics and insoles and whatnot. They finally come see us and we're like, all right, let's lock this up. I'll put them immobilized at 90, right? And then as things get better, usually around that 3-4 week mark, things are getting better. I'll unlock it. And the device, it transitions. It's not like you're using multiple different devices. You're unlocking this. You're taking that little tab thing out and you're sliding it to the bottom. And bam, you take it from locked at 90 to being able to hinge a slight amount, slowly progressing them back to that full range of motion, which is genius. I don't know if that was your idea, but 100%, kudos to you.
I'll take credit just because no one else is here to take it. Okay, no, I'm teasing you. Not my idea, but I agree. It's genius, and it's one of those things where we're so lucky in medicine to be able to benefit and allow our patients to benefit by the great ideas and the genius of others. So this is one of those things where, again, hats are off to the team that designed and made and continues to make better, because they've done a great job of just allowing us to provide that continuum of care and, again, meet patients where they're at and allow the system to progress as fast as it has.
So we already talked about the features and benefits. Oh, I have your commercial here. I don't know if you want to sit through that. If you guys are bored and you really want to see the benefits, I mean, honestly, I'll do like a quick preview. This is honestly exactly what I see in the clinic all day. Patients come in with these big clunky boots, aren't able to get around. They'll ask you, is this safe to use while driving? Is this safe to use on stairs? Is there something I can do to my boot to make it shorter? And this is the aftermath. I mean, I put them in the TayCo ankle brace and bam. Honestly, you can barely, if this guy had his trousers pulled over the end of that brace, you would not be able to see it. You'd barely be able to tell, the difference. It's a phenomenal device.
Yeah, absolutely. No, it's been a really big difference maker. And again, look at the positives in terms of, OSHA approved, right? How many nurses do you see that have some kind of midfoot, rear foot pathology, ankle pathology, right? Rear foot ankle pathology that needs a boot from the amount of inflammation or damage that's potentially there. But they go, well, yeah, but, Meyers, I can't wear this to the hospital. And so, then we're kind of stuck. Okay, well, here's your boot and wear it all the time when you're not at the hospital. And, we try to work around their life. But then you give them something like this and they can wear it 24/7 all the time, functional, OSHA approved. I have yet to have a patient that wasn't able to use this at their job. That includes construction workers, shift workers, steel-toed boots, composite shoes. Only one.
The slip-resistant bases, I get that all the time.
Yeah. Yeah. Only one time I've had a situation was someone that does sterile processing, right? They zip up in the bunny suit every day and they got the breathing tubes in their helmet. That's the only job of all the, 30, 40 feet I see every day. It's the one job where someone said, hey, I talked to corporate HR. They said I can't wear it. It might rip the suit. But everybody else has been approved so far. So I think 1 out of a million or whatever I'm at now is pretty good.
Oh, yeah. These are so simple. It's a slam dunk in my book. And then the hinge conversion. This is literally my favorite feature in all of this. The fact that you can, I'm going to jump ahead. The fact that you can convert this from locked hinge, and they'll show you, there's a little device that you slip in and out. You convert this from a locked 90-degree position to a full hinge range of motion. So it's like you take this patient that's coming in with this acute pathology, angry, inflamed. You want to immobilize. And then, bam, you get them better. And they're like, well, what am I going to do after this? Because, they have a foot deformity, they're not a candidate for surgery, or their work won't get them time off, or whatever other social problems they have going on. And you're like, let's get you a long-term solution. The old way we would get around this is you'd have these custom molded ankle foot orthoses, and they worked well. But the downside of those was the fact that it would hug against your skin, right? And it was counterintuitive because the fact that most of these patients are swelling, they have this problem. At the beginning of the day, it's not so bad. They lace them up nice and snug. And then as the day goes on, you're getting chafing from the actual device that's supposed to get you better because of the swelling that you're having as the day progresses. And this fits right around your shoe. It goes over, you have your socks on. It can go over your trousers. You can loosen it and tighten it. Super easy. It's Velcro, right? And it's padded on the inside on top of that. So rather than these leather devices that kind of hug your skin, you have this device that fits right outside everything, and it's literally it's a life changer.
Yeah, no, it's big. The AFOs, those big gauntlet AFOs, and even the Ritchie braces. I mean, I have a lot of complaints that come with those. We have a podorthist here at house, thank God, because the number of modifications and adjustments necessary for this custom brace, right? This is a custom brace designed exactly to their leg, and it still has to be adjusted all the time. So I agree that the Ritchies and those braces, the gauntlets, the Arizona styles, those are tough. They're tough ones to be functional and usable. So for all of our young athletic patients and on weekend warriors and any patient I have that's more ambulatory, right? And doesn't matter if they're 20 or 50 or 70 or 90. I have patients that come in here in great shape. The TayCo's been a great alternative. I tested the waters at first with people that weren't good candidates for the cam boot, at all, right? It was like, okay, this person's probably a fall risk. Let me try this new brace. This person says they've tried a cam boot before and it hurt the other body part. Let's try this
That's
TayCo
hard.
Brace. So I think I tested the water right toes in there because, new things you never know, right? So you want to kind of go in there a little bit gently and easily. And so I wasn't a believer at first until I was able to get some time and experience with it. Then game changer. When people come back and talk about their satisfaction is so much higher, their outcomes were better, and then all of a sudden you read all the data and studies that these guys do, and you read that across the board. Patient satisfaction scores are higher. Patient outcome scores are higher, right? The amount of control that you can get with the TayCo Brace versus a cam boot's actually better anyways. And then it alters your gait way less in almost every component you can think of, right? People are better balanced, their step rate and cadence and velocity, everything stays much better. So it's almost like if all the data points to one thing, you can't keep denying it for too long. But again, like we've talked about, how do you change an entire institution and world away from what they've done for years and what they trained on for years? So it's such a slow process. Not everyone is excited to take on new technology and new good ideas, Dr. Hussain. You're ahead of your curve, my friend. You're one of the gems out there. So I think it's just doctors telling other doctors how great it is and continuing that trend that really does a good job. And I think as TayCo gets bigger, I'm hoping they advertise more and do some patient outreach things, because sometimes you can't keep denying a brace if all your patients come in and go, hey, instead of that boot, I saw something on TV that's a different kind of brace.
Yep.
Then it kind of generates that conversation with the doctors, and eventually they'll go, all right, I know I'm kind of stuck in my ways, but maybe it's a good idea. I can help patients better. So I'd love to see something like that in the future for those guys to help, progress that way for the rest of the profession.
Yeah, I love that you said that you started off with your most difficult patients first, because that's exactly what I did. I had patients that were either, honestly, I'm thinking of one patient in my mind, PTTD, posterior tibial tendonitis, severe flat foot deformity. He's pretty much walking on the inside of his ankle, and not a candidate for surgery, had heart problems, had history of strokes, older, and, severe lymphedema, the whole shebang, worst surgery possible, because he'd be immobilized, which is a high risk for heart problems or PEs, pulmonary embolisms. He has swelling, so he'd pop his stitch. The worst on long-term blood thinners, bleeding problems, all that. So he was in an AFO from a different doc, and he brought his AFO. He had like a bag. He brought a shopper with his previous ankle foot orthoses, and I was like, let's try a TayCo ankle brace. His problem was that he'd get chafing on the inside of his ankle where the swelling would occur as the day would go on. That tibial tuberosity and that navicular tuberosity where that foot is literally deviating out, and he's walking on that site. So I put him in the TayCo ankle brace. It was on our shelf. We had one of the pre-made, what's it called? Prefab, non-custom versions. And I was like, all right, let's try this out. Put him in it. He wore his favorite shoes, which was a plus to him because he didn't want to go back into a boot because, back problems and whatnot. And honestly, it was a slam dunk. He's like, this is night and day. This has honestly become a life changer for him. He went back to full activities, not full, but to where he was before he kept on having all these PTTD problems. And it's just, it's one of those things. You're picking your worst candidate and you're like, oh, this is actually working for him. Maybe I should use this more and more. And that's honestly where I progressed. I started, hard, difficult patients. And now I'm like, oh, I should probably be using this a lot more now that I'm able to treat the worst of the worst.
Yeah, that's a great way of saying it. I think, again, across the board, it's been better than the walking boot. It's lighter weight. It's OSHA compliant. No leg length discrepancy. It's more comfortable. It works with people's favorite shoes. It works with custom orthotics or whatever they're in. So again, across the board, pretty much every facet you can think of, it just outperforms.
So what are your favorite things to use this for? So I'll say up front, my favorite things are, recurrent lateral ankle sprains or acute injuries that are really bad, severe ankle sprains, PTTD, posterior tibial tendonitis, and severe osteoarthritis. So we have patients that are severe osteoarthritis in the midfoot or hindfoot, and the ankle, and they're not candidates for any type of surgical correction, fusions or total ankle replacements, which I'm kind of transitioning to more. But what are you using these for? What are your go-tos for this?
A lot of the same. I've expanded it pretty far in any kind of rear foot or ankle pathology across the board. So ankle sprains that come in there, we go in there pretty much right away just because, again, locked to hinge, or we're able to kind of progress with the patient through that side of things. I like for a lot of Achilles tendonitis as well. As long as the shoe doesn't fit too snug around the posterior heel, so that way if they have that really inflamed bursal, sac as well, then I found that to be really helpful and beneficial. I would say PTTD as well, or perineal tendonitis. Again, that all kind of just locks that rear foot motion into place. So those are probably the most common ones that I see on a regular basis in more of a sports-based practice. It's funny. I heard Dr. Flynn at South Bend Orthopedics. I think he was on a call, was mentioning doing it for like Weber B fractures, and then so I started, and then it was so funny how I swear that week I had 3 isolated fibular fractures that were really not up. I mean, they were in a pretty good position and pretty stable. So where people come in, they go, I sprained it, and I've been walking the last 4 days. It's just really swollen, but it's kind of sore. And my wife made me come get it checked because I'm hobbling a little bit, and I think I'm fine. And I just sprained it real bad. And you're like, no, I actually have a break in your bone. And so and once I heard them say it, I said, let me try it on these. And so I said, hey, instead of the boot, we're putting you in this. We're going to lock the hinges. And I figured they'd be good just because they came in walking on it. That any kind of support's going to be beneficial, right? And they all did great, all 3 of them. So it was kind of so funny how we talk about it in that week. We did it too. So I think more is coming out that way. They've got a lot of cool research ideas in the pipeline. They're comparing this to the Arizona balance brace that was developed by Dr. John Moore. Used to be called the Moore balance brace before. That's transitioned and changed names a few times, but they want to compare some of the studies they're doing with that. Yep, there you go. So a few of those slides are coming out that way. So again, then there's a few other articles listed on the website as well. If you really, for those of us that like to nerd out and read all the extra articles. Yeah, I know. I'm with you too. It's really cool how, again, just a comparison just keeps blowing the cam boot out of the water. I mean, the only one stat that was a little bit close, I think, was inversion forces, right? They said, hey, inversion, it's pretty close to a cam boot. But everything else across the board, eversion was like 4 times as much, if not more, and everything else was just so much higher. But again, it's all the positives from a patient perspective, right? They don't care about that much stuff as you and I do, probably. But, again, the functionality of it, I think, is what people love the most, and that's really where it's really locked home. But also, Dr. Furlick admitted to, is just the number of, pro sports, collegiate sports, they tend to stick with the best of the best, right? There's no brace that's too much money. There's no device that's too much money. If the doctor says we're doing $10 million stem cell injections, then the NFL says, okay, let's get 10, right? There's not a number that phases them at all. And for them to get behind this kind of brace for a lot of their sports has really been cool to watch. So, it's an injury prevention modulus in some ways, but also a quicker return to sport because you just have that rigid construct. So I think to watch them adapt this brace so quick just goes to show the everyday weekend warrior like myself that it is as functional as we think it is, and it can be used at that kind of higher, activity level and still be just as great as we think it is. I think the only sport that really is tough with that is soccer players, just based on some of the inversion, eversion forces they need for cutting. But again, NFL guys, a lot of, and lacrosse it works really well with. I know you see a lot of pictures of those on there. But to watch so many NFL and NCAA teams get behind the product is just kind of helps solidify that it is as good as we think it is for our patients.
Oh yeah, 100% agree. I have young athletes, high school and college athletes. We're a very college-based town here. And we'll have them in the brace, immobilized. And then once they transition to that full range of motion, they're able to go back and do some light practice and then hopefully work their way back out of that brace and back to full activities without any type of problems. It's phenomenal.
It's awesome.
Yeah.
It's becoming an athletic trainer's dream brace, right?
Yeah. For a while, it was those kinesiology taping strappings. Remember those? It was real fat. And you're like, all right, this is going to give you some support. But we really need something a little bit more rigid,
Right. Totally.
All right. Well, I mean, total ankle replacements. I know I picked your brain on this before we started recording. What do you think the future of total ankle replacements as far as TayCo ankle brace goes? Because total ankle replacements and TayCo brace, I feel like are synonymous now in a lot of doctors' mouths, because we're looking at the best of the best. Before, when people used to have osteoarthritis, we'd fuse the ankle, right? We'd talk about different options, and pretty much the gold standard used to be fusing the ankle. Now it's flip-flopped. The last 15, 20 years, total ankle replacements have just progressively gotten better and better and better. And we're trying to do the best things, and the TayCo ankle brace Um, Now the standard of care, hopefully, to be for total ankles, immobilize the first 2-3 weeks. Let that swelling come down, and then pop him into that TayCo ankle brace and get him that full range of motion. What do you think?
I agree. No, I think it's been good because whenever I went through training with our foot and ankle ortho guys, when we did total ankles, we would keep them non-weight bearing just for the swelling, right? Because the construct and the implants were strong enough to sustain weight bearing right away, but it was swelling we were worried about, so we kept them off. And then once they had good control of the swelling, it was all right. Well, here's your boot, and only take it off for PT. But so do these range of motion exercises at home, and we'll work on stiffness if you get it. And so I think being able to have again the construct that allows for that range of motion at an earlier on standpoint has really been a game breaker. And obviously, it's a protocol. Dr. Schweitzer is across the street from me. Carl's a great guy. He's a great surgeon. Takes great care of his patients. That guy is overwhelmed with the number of people that Duke's a big feeder system, and they keep him super busy. But he's again great guy, great doc, and great protocol that he follows. And so for someone who sees the volume that he does to get behind something like this and be so excited for it, it's just again further iteration of how standard of care continues to improve, which as you're kind of alluding to, is that improves the outcomes of these things. I think
100%.
that we're keeping that post-operative stiffness lower, and again deconditioning is less, and I think that people are getting back to that more functional side of life better, right? Where the knee and the hip patients sometimes say, took me 9 months or a year, but now I'm finally in a good place and I feel like I'm strong and I'm myself. And that's despite early weight bearing and things. I think that a brace like this just allows people to progress that much faster and get to where they need to from a post-operative thing standpoint.
Yeah, I mean, I'm a little bit less aggressive than he is. I typically have him start weight bearing around that 3-4 week mark in their the brace and boot and whatnot. But that 2 week mark is great. It's just for the fact that when we do our knees, right, and when we do our hips, they're literally walking that same day or next day. I remember when I was on rotations and we were doing nips and knees and hips and whatnot, they would have the PT come through if it was early enough that same day, if not the next day early in the morning. They're walking them. They have them in those continuous passive motion devices.
Yeah, KPMs.
Yeah, and what we used to do, I mean, this is a little bit older, like 5-10 years older, total ankles, we'd completely immobilize for 6 weeks. All right, wouldn't touch them, don't want to see them, keep that boot on, keep that cast on, whatever it is. And now it's like a full 180 where we're like, all right, we want you passively moving that ankle. I had them in a soft splint the first week, right? And I'm like, all right, I just want you moving that ankle whenever you're sitting around. We want to keep that swelling down, keep that elevated, and usually around 2-3 week mark, the skin is pretty much healed up. I'm like, all right, let's get this hopefully moving. I want you weight bearing. I do a tripod gait first, right? And then I'll have them weight bearing in that the brace, usually around that 3-4 week mark. As they're comfortable, they'll toss those crutches away and full range of motion. And then the nice thing is, you get that little device out of there. You get them from 90 to light range of motion, and bam, beautiful. They're just cruising now.
Totally. You're making the world a better place, Dr. Hussain. Give yourself a pat on the back, my friend. Well deserved.
All right. Well, am I missing anything on any of this? I don't
know.
No,
you've done a beautiful job. I give you highest remarks. Not that my opinion matters for anything, but thanks for making me feel special.
It makes me feel great.
Good. I'm excited to hear it. No, I think that, for anyone who's curious or interested, go to the website. Lots of great information. That's for patients and that's for doctors.
Yes.
And again, as a patient listening to this, ask your doctor about it, and bring it up to them, because sometimes it takes the enough patients ask about something and it makes the doctor rethink their choices, because sometimes we're just curmudgeony doctors and we're stuck in our ways and we can't break out of our shell, right? We're trapped. And so having how this patient's encouraged, and at least get your attention to it, then it makes you kind of reevaluate the way you're doing things and perhaps that better standard of care. But again, there's great studies. If you like studies, there's great protocols that are on there as well. I know that you can reach anybody who's on the board over to the panel there, and we all love this stuff. We just like to help patients. I talk to people about everything, and whether they're my patient or not, just because I love this stuff and I like to help people. So I think that everyone on the board's the same way. So if any doctor ever reached out and was like, hey, doctors, so I do this right now, and I'm thinking about switching to this, and with the brace, what do you think? And you'll get a lot of good information feedback, because once you build the confidence interval for us, we all just start trying this on a lot of things to see what we're missing and what we can improve the patient outcomes and the patient care for.
Beautiful. Well, thanks again. That is Dr. Jordan Meyers. If you are in North Carolina and you have foot and ankle problems, go see him. Otherwise, we'll see you next time on the Pod Doctors.
Thanks, Dr. Hussain. Thanks, everyone.